SG2 Perspectives is being renamed Edge Perspectives. Same great host, same great content. We're going to expand the way we cover data-driven market intelligence, quality, and operations. This is Edge Perspectives, a weekly conversation about the biggest insights that span market intelligence, quality, and operations with the Vizient Strategy Intelligence team and other experts.
That is the big question. Every payer segment, every organization is also on a different journey. APMs have evolved over the last decade. At the same time, APMs models have evolved. They're very complex. This is not just a contract exercise.
Welcome to Edge Perspectives. I'm your host, Jayme Zage. I'm excited to have three of my colleagues here with me, Janelle Kwan, Mahaya Walker, and Jen Goff. They've been doing some exciting, intensive research on the new payment models and the payment landscape. We see a need for a fundamental shift in the entire payment ecosystem, and it's been slowly happening. They're going to talk to you about their research, what the data is showing, and how consumers, payers, providers, health systems come together and are affected and shaping this moving forward. Welcome to this episode of Edge Perspectives. Janelle, there's a shift to value that's been going on. We've been talking about this for over a decade. What is different about today's environment?
There are some evergreen drivers like cost management that continue in our research. There are additional tailwinds that are helping to accelerate adoption of some of these APMs. One of them is the intersection with healthcare consumerism. The model of care that healthcare consumers want aligns with how we deliver care in an APM. Increasingly, we know that our patients want a unified care experience that allows them access. It's personalized, it helps them address wellness and prevention, and it's affordable. They know how much it will cost. The bottom line there is if you advance your consumerism strategy, you're advancing your ability to shift to an alternative payment model. I also want to have a nod to the role of technology, particularly the onset of artificial intelligence. It's allowing us to be able to optimize some of those workflows that have hindered APM adoptions. Now we have the ability to have real-time data capture, data integration, so we can track our performance and more quickly spot larger patterns in our patient cohorts. We can automate a lot of the high-volume operational tasks, like documentation, that ate up a lot of our workforce's time, and use prescriptive analytics to guide decision-making. What is the right form of treatment or intervention or monitoring for specific patients? Technology is creating a way for us to monitor, manage, and care for patients in an APM at scale. That's exciting and helps us address some of the long-standing challenges. Jen, I know you have some thoughts here.
What also has changed over the last decade is clinical advancement. This is going to help organizations, even payers, think differently about how we deliver care, which ultimately will impact the total cost of care. Our toolkit now for clinical innovation has changed quite a lot over the decade. When value-based care and alternative payments came out, it was all about how do we reduce the cost of care management. What's changing is innovation around how we diagnose diseases, how we treat diseases. Now it's changing the clinical pathways, changing how we care about disease management. The big example that hits the news is really around GLP-1. It's such a great example of a new innovation that manages chronic diseases, but multiple chronic diseases. We've looked at claims data. Those that are on GLP-1, their utilization for ED and inpatient has decreased. Surgeries have decreased for that population. It started off as a diabetes drug, but it's now expanded to obesity management, to reducing cardiovascular events, to sleep apnea. It's making its way into substance use. They've done studies. Those that are using it for diabetes, they've seen that their substance use, ED, and inpatient utilization has gone down. It's making an impact across multiple diseases, and it's a pretty large population, so it can impact the healthcare utilization. What comes up a lot with drugs like GLP-1 is how expensive they are. They're expensive in the short term, And when it comes to alternative payment models and value-based care, we need to look at the long-term impact of some of these clinical innovations. GLP-1 is just one example, but there's a lot of advancements in oncology, cardiovascular, diagnostic on how we diagnose individuals. So we're going to continue to see more targeted care models that avoid unnecessary utilization and move care more to lower cost settings. And that's going to impact how we think about value-based care and that total cost of care. Do these innovations reduce the downstream of healthcare utilization, and then the long term bends the curve? Because that's more promising when it comes to value-based care and alternative payment models.
Mahaya, how are some of these changes reflected across the different payer segments?
The top line is that there's movement towards APM adoption across the board, but the journey and the pace of that adoption looks different across different payer segments. We see the most adoption and the fastest pace of growth towards APMs with traditional Medicare and Medicare Advantage. This is no surprise. CMS is leading that charge. As payer mix continues to shift towards Medicare, their influence overall just continues to be greater. Coming out of CMMI, we see continued growth of some of these long-standing programs like MSSP, as well as the new long-term enhanced ACO model, which is building upon what ACO REACH had already established. Generally, CMMI is also pushing out more mandatory models, and they're getting deeper into those specialty-specific models. The Medicaid story is different and is more state-dependent, but there's still moderate growth and pace towards it. The Medicaid population is expected to shrink as we think about changes stemming from federal policy, but we still see innovation and progression in the Medicaid space in general. One thing to call out here is the continued progression and integration of behavioral health and physical health with the innovation in behavioral health model, as well as the continued growth and success of certified community behavioral health clinics. The commercial space is the one everyone wants to know about, and this is the one where we see the greatest variation and the most market-dependent activities. Rising cost pressure is driving the story here. Across the board, employers and employees are experiencing premium increases and are looking for cost reliefs to relieve that pressure. Your larger employers better positioned and more equipped to pursue APMs at scale through things such as bundled payments, as well as direct contracting with provider organizations. And then lastly, the uninsured population, particularly as we anticipate this population to grow significantly in the next 5 years. This is one of the most challenging segments to implement APMs, but it's also the most critical in terms of cost control and prevention. The big story here is the continued growth of community-based partnerships, helping to provide access to primary care and preventative care to curb that downstream utilization and spend, but also to address social needs. Top line in terms of what we're seeing across segments, but at the highest level, this journey looks different across payer segments, but generally all segments are moving in the same direction on different paths towards alternative payment model adoption.
Thank you, Mahaya, for that overview. Research and member conversations about the shift to APMs shows variability by health system and market. What steps can health systems take to guide its approach?
That is the big question. Every payer segment, every organization is also on a different journey. APMs have evolved over the last decade. At the same time, APMs models have evolved. They're very complex. The reality becomes this is not just a contract exercise. It's not just, I'm going to contract an APM. The question becomes, what is the right strategy based off of my market realities and my organizational capabilities? In our publication, we give our members a framework. It's a 3-step process to determine what is the right strategy for my organization. And it starts with, where's my market at? How fast is my market moving towards these APMs? The innovation readiness model is what we use in our publication to help our members understand what pace my market is moving to adopt more innovation, particularly innovative payment models. This allows us to get a sense of, is my market moving very fast? Is it slower? If you're in a market that has economic pressures, you have the ability to partner between payers and providers or even employers or high Medicare Advantage, and you have active participation in those CMMI models, we know those markets are pretty fast. They want to move. They're already showing signals they want to adopt innovative models. But for other markets, there's still conditions that support fee-for-service. Fee-for-service is not going away. It's still there. And in some markets, it still makes sense to continue to have that, balancing it with the APMs. Before you jump in, you have to understand your market. First, where's my market at? Is it moving fast? Is it in the middle? Or is it slow? That shouldn't be our only step because the market only tells us a piece of the pie. The second is taking an assessment of your organization capabilities. Before you take on too much risk, make sure you have the capabilities to manage that risk, coordinate that care, leverage that data and analytics that's continuing to advance. How do you leverage that? And how is my organization ready culturally to take on more risk? That is starting to look through what is our capabilities. And we in our publication have a whole framework of what are those capabilities and what does it look like as you progress and mature as an organization. That's continuously important. The third is mirroring them up together and aligning them to a way to say, here's where my market's at, here's where my organization's at. What's that intersection to determine what's the right strategy towards innovation payment models? Because if my market's moving very fast and I have built the capabilities to take on risk-based contracts, my focus should be about how do I scale that? How do I take on more? If my market's ready, how do I keep building more risk-based contracts? If I'm in a market that's slow and I have my capabilities, it's going to be harder for me. It's more about how do I balance fee for service with APMs and work towards those progressive payers and employers to help move the needle and move the market forward. Versus if my market's slow and I'm slow, my focus is building internal capabilities so when the market moves, I am ready. Aligning those two together to help with that base. So when we do talk about that APM strategy, it's going to look different by payers. Once you find out where my intersection is, my strategy at that payer segment might look slightly different. The last thing is once you set that strategy, you're going to need to continuously look back and evaluate my market as well as my organization capabilities to decide what's moving forward.
Jen, that's a rich description of where health systems need to go. It reminds me how they have to live in this uncomfortable space where some of their patients are getting treated differently because they are on an APM and they can make it work with some of the supports that they put in place. And the fee-for-service patients, they just can't afford to do that. Part of this is knowing how fast you need to move, reducing that stress or that negative feeling of we're not treating all of our patients equally too. Given that uncomfortable tension between patients on APMs getting treated a little differently than those on fee-for-service payment, Janelle, what characteristics of organizations are important for driving that success in APMs?
It is a mix of organizations able to manage, understand, and keep a pulse on what's happening externally and be responsive to that. Also exercise control over what's happening internally. And one of the common lessons we learned from organizations who had stuck with it and saw some of the impact is that culture matters, specifically your culture around execution. Organizations who benefit from this are open to experimenting and taking on pilots, but equally important, using the learnings to figure out when do we need to do something different or when do we need to stick with it. So that orientation towards pilot and experimentation. There's a shared trust across the organization, operational, clinical, financial. They equally share ownership over the results. There's a degree of vulnerability about having problems identified and collectively working together to solve them. They don't just talk the talk on data-driven decision-making, they actually use it. And part of that is making sure leaders across the organization feel equally versed and comfortable not only learning from data, but using data as the foundation for driving some of the decisions around their patients. That can help facilitate when different patients might be on different journeys. This is key, and the one that often gets most overlooked is that need to communicate clearly across all the stakeholders, from decision makers to those executing on that decision. What are we trying to do? And then ensuring that that message is consistent across those different stakeholders. When we talk to leaders, they agree about the philosophy of APMs, but where there's difficulty is bridging what they're trying to achieve with getting everyone to mobilize and act on it.
That execution culture is critical. The other piece that's just as critical in terms of the success of these relationships is the payer-provider relationship. Success hinges on collaboration with both parties working together to advance care and payment reform. Both parties have to be equally invested in sharing accountability for quality, outcomes, and total cost of care. And this requires aligned incentives and data sharing on both sides for these arrangements to properly be implemented, but also to be sustainable. Even if you're an organization that has a provider-sponsored health plan, that alone is not going to be enough to ensure success. The payer and provider side of the house have to be closely aligned, and same rules apply with them as well.
One of the things that we've talked about a lot is we're getting to a point where we're topping out for APMs. When we look across all the payers and all the different markets, given all the nuances, what is the future trajectory for APM adoption?
We alluded to the fact that particularly with CMI and specialty, APMs have been centered around primary care. Primary care was the first one to implement it. It made the most sense. They have more influence when it comes to managing a population. We already have that shift more towards specialty care models. As we add more specialty models, they all have different metrics for measuring. What's going to help us is as we start to integrate specialty more into APMs, we're going to get to a point where we simplify how we're measuring APMs. And instead of having like 100 different metrics as a health system I have to measure because I have multiple contracts, we're going to get to a point where if these are the main metrics we have to measure for our outcomes, we're still in the phase that right now it's a lot of different metrics. And trying to measure all these metrics is on an infrastructure with advancements in AI and data analytics. And as we start to move more integration of specialty and then more relationships between payers and providers working better together, a little bit more simple on how we measure our outcomes that are tied to our contracts. That's how we're going to move the needle.
In terms of the future trajectory, it's a little bit more niche and specific to the commercial segment, but we can expect to see more growth in the direct to employer space. This is one of those topics that's cyclical in nature. Right now, it's a hot topic. Everyone's trying to get a piece of the pie here. Direct to employer varies pretty widely. It can range from on-site or near-site clinics all the way to full employee coverage. These types of programs are harder to implement as the scale and breadth of those services increases. However, if done well and done at scale, there's huge potential here for provider orgs to capture more commercial volumes, as well as for employers to be able to start to control that cost curve, which they're so desperate to do.
Yeah. What we have found, and as we look forward, is it will still be something ultimately. We see an overall shift, but it will still be something tailored and personalized to your individual market context and your organization. What I would just stress, though, is that the underlying principles of an APMs, this ability to address the totality of a patient's care, to find the most cost-effective setting and to be able to manage them, are things that you are already working towards, regardless of whether or not you are in a formal APM arrangement or not.
I love that. As a final thought, Janelle, you're already doing the work, putting in the effort to get that infrastructure in place to be ready for the payment model. So many of our clients are already there, and that is a great optimistic perspective. Thank you, Janelle, Mahaya, and Jen, for joining me today to share your latest research on alternative payment models. And thank you to our listeners. Until next time. Thanks for listening to this episode of Edge Perspectives, a podcast from Vizient. If you have questions or ideas for future episodes, please reach out to us using the email address in the show notes.